All right, welcome. I recognize some of you, and if you all stood up and turned around, I'd probably recognize a few more of you. I have been at Grand Itasca for 5 years, just in February, so just 5 years and a month. I have gotten to know some fabulous people here, and I hope I get to know more of you. I came from Iowa. That's where I practiced before. I trained in Des Moines, and then I practiced in a small town in northern Iowa, in Waverly, Iowa. I grew up in Rochester, Minnesota. My grandparents lived in Dora Lake for about 35 years, which is how I became familiar with Grand Rapids. And when I needed a change, I decided coming up here to practice instead of just vacation would be a good thing. So I enjoy it immensely. So tonight we're going to talk about colon health. A lot of changes lately, and March is Colon Cancer Awareness Month, so you'll probably see a little bit on the news here and there. But I wanted to give you a little bit of background about colon health. And tonight we're going to talk about what colon polyps are and what colon cancer is. We're going to understand that colon cancer can be prevented in most patients. I want you to understand the difference between an average risk patient and a high risk patient, and understand some of the options for screening for colon polyps and colon cancers. Okay, so that's our goals. So what is the colon? The colon, also known as the large intestine, it's 5 to 6 feet long. So I tell people, your colon is longer than this. Okay? Its job is to absorb water from waste and to store the waste so that at a convenient time, you can get rid of the waste. That's how it works in most people, and that's what we try to get it to do. So the anatomy, this is the anus, this is the cecum. The colon goes in between there. So you have the sigmoid colon, the left colon or descending colon, the transverse colon, then the ascending colon. This little squiggly thing hanging off the cecum over there, that's your appendix. And when I do a colonoscopy, many of you have seen that I take a picture of the opening of your appendix. Even if you don't have an appendix, you usually still have an opening. And that's how I know I got to the end. I also go a little bit of the ways up into this small bowel called the ileum. So what is normal for that 5 to 6 feet of large intestine? No bleeding with bowel movements, no pain with bowel movements, 3 bowel movements a day, to 1 bowel movement every 3 days. Those are considered kind of the normal ranges. So abnormal for the colon, bleeding with bowel movements, bleeding in between bowel movements, pain with bowel movements, pain in your abdomen before or after bowel movements, changes in frequency. If you've always been constipated, and I hear from people all the time, I've been constipated since I was a baby. If you've always been constipated and all of a sudden you have 3 bowel movements a day, that's a change for you. Even though it's normal, it's a change for you. And if you've always been on the loose side, and now you're going to the bathroom every 3 days, that's a change for you. And those are things you need to talk to your doctor about. Changing the size of bowel movements is also something that people notice. That's a sign of something that's far, far along. So not usually what we hear anymore. Back in the day, some of these things. Normal colon lining. Nice and pink and smooth, shiny, healthy. A lot of times when I show these things to people, they say, oh, what are these white things? That's just the light reflecting off the moisture in the colon. The red things are blood vessels. That's normal part of the colon. The dark stuff down here is just where the light doesn't reach in the colon. So that's nice, normal, healthy looking colon. So the fine vasculature is easily visible, those blood vessels. Surface is shiny and smooth, and the folds are just normal thickness. There's no extra areas of thickness or bumpiness there. Why do we care about colon cancer? So colon cancer, about 135,000 new cases in 2016. Okay? Approximately 50,000 deaths each year. The lifetime risk of colon cancer, it's 4 to 5%. That means 1 out of 20 people. So we've got more than 20 people in here, so there's going to be at least probably 2 who have or will have colon cancer. Decreasing mortality, that's the good news, and decreasing new cases. Part of that goes along with screening And part of that, we're not sure how we can explain why it's decreasing. Now, that's decreasing in a certain populations of people. There is some new data that shows that colon cancer is increasing in people under the age of 50 right now. Not really sure why. My guess is going to be that they're going to find out that it has something to do with diet and environment. Because most of you all didn't have Doritos and McDonald's on a daily basis when you were growing up. But those of the population that are under 40 have spent a lot of time with that kind of food. And I have a feeling that some of that is going to come out. What are colon polyps? Colon polyps are growth in the colon. Normally, when colon cells touch each other, the rule is that they have to stop growing. They touch each other, no more growing. If colon cells are touching each other and they keep growing, then they make a bump. And then you don't have that smooth, shiny surface of the colon. You have a little bump. The more those cells grow, the more rules they break. The more rules they break, the more likely they are to turn into a cancer. The larger the bump is, the higher risk it is for turning into a colon cancer. Most polyps are either hyperplastic or adenomatous. Now, those are two different kinds. Hyperplastic polyps never will turn into a colon cancer. Adenomatous polyps, not a lot different by looking at it with your eyes, but under the microscope, that one has some characteristics that tell us that it has a chance of turning into a cancer. Now, that chance isn't very high. I have to take off a lot of adenomatous polyps to prevent a colon cancer, but I don't know which ones will turn into a colon cancer and which ones won't, so I take them all off. Once they're in that jar headed to the pathology lab, I know that's never going to come back and bother you. Flat polyps. Now, this is something that we've just started knowing about because our definition and our cameras and our light lets us see these. 15 or 20 years ago, we had no description of something called a flat polyp. We didn't know they were there, but they have a higher risk of turning into a colon cancer. And you can just barely tell there's a little bit of fluff here. It's almost like somebody put one of those fluffy bathroom rugs down on the colon. Okay? It's not super obvious, but it has a higher risk of turning into a cancer than a polyp like this. This is a stalked polyp or a pedunculated polyp. And it looks gigantic here, but that's not really much bigger than my pinky. Okay? This wire is how we take off those polyps with a stalk. I put that wire around the polyp, I lasso it down, it gets a little bit of cautery on it, or it gets hot, and it burns through the base of that polyp, and then I suck that polyp out of there with my camera. It's pretty cool stuff. And as I tell my patients, every polyp I take off, I might be saving somebody's life. All right, colon cancer, that's one way that colon cancer looks. So it's thickened, it's bumpy, and when I touch it with my grabber, it bleeds like crazy. It's very fragile. That's why one of the things that people notice if they have an advanced polyp or a colon cancer is blood when they have a bowel movement. Okay? We know that normal colon polyps make a little bump that can turn into a bigger bump. As the bigger bump grows, it has a risk of turning into a cancer. So our goal is to find these before it turns into this. Okay? Now, this is a polyp that has some cancer in the top, but we can take that off there at the base and you don't need to have a surgery. As long as that base doesn't have any cancer cells, we can just take that off with the scope. So even finding a big polyp with cancer in it doesn't necessarily mean you have to have surgery. Okay? So how do we find the colon polyps and colon cancers when they're small and easily treatable? We can look at the colon, or we can look at the stool. My mom is super proud that I spent about half of my day talking about poop. I was never allowed to say that word as a child. You had to go potty, you didn't have to go poop, and now I talk about it all day, every day, and makes her nervous. All right, so little funny break. I need a courage, I need a heart, I need a brain. I'm over 50, I need a colorectal exam. All right, looking at the colon, we can do that 3 ways. Colonoscopy. You can do something called CT colonography, or we can do flexible sigmoidoscopy. We're going to talk a little bit about the differences between these. So colonoscopy, and I've got a funny about this picture too. You're sleeping, the best nap you've had since you were an infant. I use a camera. I insert it into your colon. I put air in your colon so I can see everything. I look at a monitor to see what's inside the colon. I take pictures. I take polyps off if I see them. And on the way out, I suck the air out, so when you wake up, you might be a little bloated, but you shouldn't have cramps or pain. Now, the funny thing about this picture is I sent my slides to the girls who helped me, and they said, oh, your slide of the colonoscopy is kind of blurry, so I put a new one in there. And I looked at that, and I was like, oh my gosh, that doctor doesn't have on gloves. So that's my funny about that, but it is clear. So colonoscopy, we go up, we make those twists and turns because my colonoscope is flexible, up and around the corners and down to the cecum so we can see that opening of the appendix and the small bowel. Colonoscopy has a lens, the colonoscope. It has a little hole where I can irrigate or squirt water through. It's got a vacuum cleaner. It's got a light, and then it's got this channel that I can put instruments through. Now the instruments that I use are about 3 millimeters. So a millimeter is about the size of the silver part of the pen. Okay, so it's tiny. So that those polyps look big, but they're very tiny. This is kind of what the report looks like. This is that opening to the appendix. That's healthy looking colon and healthy looking colon. This is CT colonography. So for CT colonography, you still have to clean out. You still have to take the medicine. That's what everybody hates about colonoscopy. And then you go into a CAT scanner. For those of you who've had that, it's a big tube. And they put a tube in your bottom, and they put some contrast in. See the real white dye? They put that contrast in there, and then they do a CAT scan. And then they have you roll over, and they do a CAT scan. And then they have you roll over and do a CAT scan. And if you notice the black part in the colon here, that's air. So they put some air up in there too. So they make you real bloated too. A lot of people think that's very uncomfortable because you don't get a nap when you're doing this. What you do get is a computer to take all of the pictures, and it creates a virtual colon. So this looks kind of like you're doing a colonoscopy, and it's all done with pictures and computers. What it can't do is, if you find a polyp, it can't take it off. So if you have that done, you have the contrast in there, and they find a polyp, you have to come back after you do a prep again, and then you have to have the colonoscopy and get your colon polyp taken off. So this was really, really, they thought this was going to be all the best thing next to sliced bread about 10 years ago, and then people said, no, I don't want to do that again because it's uncomfortable and I don't want to do the prep again, so it's kind of fallen by the wayside. But it's a good option for some people. Flexible sigmoidoscopy, they only look at that side of your colon, the sigmoid colon up to the flexure here by where your spleen is. Now I've got about half women in here. I say this is like getting a mammogram on only one side, because colon cancer is the same occurrence on that side as it is on this side. So if this is the test that you choose, we need to combine it with something else. You can't just do this test. So a guaiac-based stool test, this is what the older test is. You have to turn in 3 specimens. You get 3 cards, 3 separate specimens. They go into the lab, and they look, put some developer on them. They look for blood. But they're not great. And then there's something called FIT testing, which is fecal immunohistochemical testing. FIT is a lot better. And then there's a combined test that looks at the DNA in the stool, and it looks for the blood. So the guaiac test, it's the least sensitive, which means it doesn't find as much as we want it to. It's also not very specific, so sometimes it'll say there's blood in there, but it's really just because you had grapefruit yesterday. Positive, you need to have a colonoscopy. Retesting doesn't count. Once you're positive, you're positive. You don't get to have a clear bill of health until you have that colonoscopy to say there's nothing bad. It's affected by ibuprofen and Aleve and aspirin and vitamin C and red meat. It also can't tell the difference between blood that's coming from your stomach and blood that's coming from your colon. So it's not a great test. It's one that they use occasionally now. FIT test is an immunochemical test, and that looks only for the proteins that are associated with human blood. So you don't have to worry about red meat. It doesn't get positive for vitamin C or for orange juice or grapefruit. No medicines can make it go positive. It's, again, if it's positive, you need to have a colonoscopy to prove there's nothing going on, and they're recommending that you do it once a year. I've had people who got this in the mail from their insurance company. Their insurance company just mailed it to them and said, take this. It's only one specimen, you don't have to do 3. And then there's a test that combines both that FIT test and the DNA test. So if you remember back to the slide that showed that the cells, as they get bigger, as the polyps get bigger, those cells get more abnormal. This test actually looks for those abnormal cells in the stool. And so it finds, if those cells aren't following the rules, it finds those cells. And then we do the colonoscopy to look and see what's going on in there. It's more specific, it's more expensive, and again, if it's positive, then you need to have the colonoscopy. The good news about this FIT and DNA test is that Medicare pays for it. Let's look at this little video.
Introducing Cologuard.
I'm here for an important reason. Colon cancer screening. If you're age 50 or older and at average risk, Cologuard finds cancer and precancer. And it's a non-invasive test you can use at home. In fact, I'm as easy as get, go, gone. How do you get me? Your doctor orders me, and I'm delivered directly to your doorstep. There's no need for time off or special prep because I use the DNA in your stool to find colon cancer. Then you just go. I mean, collect your sample. Then I'm gone. Just ship me to the lab. Gotta go.
Cologuard is intended for individuals at average risk for colon cancer. Cologuard is not for high-risk individuals, including those with a history of colon cancer or polyps, IBD, certain hereditary cancer syndromes, or a family history of colon cancer. Cologuard, colon cancer screening that's as easy as get, go, gone. Ask your doctor if Cologuard is right for you.
I think that this is a very good test. The chance that it misses something is not known because it's a newer test. It's been out for 3 years. So instead of doing it every 10 years like you do a colonoscopy, they recommend that you do it every 3 years. My guess is that that's going to expand to every 5 years. Insurance is paying for it. I did learn of a new complication of doing it is that in northern Minnesota in January, your specimen freezes too solid. So you should not do it when it's really, really cold, okay? It also is sensitive to heat, so they do say in Florida and California and in Arizona, Texas, not to do that when it's extremely hot. But I don't think they had enough northern Minnesotans or Canadians to get the cold part of that. So I think that in the next 5 years, we're probably gonna be seeing most patients who are average risk do the Cologuard. And I'm only going to be doing colonoscopies on people who've had polyps, who've had cancer, or who've had a positive test. And because of the risks that go along with colonoscopy, this is a really good thing. Okay? The prep for colonoscopy is difficult. It can cause dehydration. It can cause electrolyte abnormalities. It is very uncomfortable. The risks of the procedure, the anesthesia is as a risk, but there's also a risk of a hole in the colon, a risk of bleeding if we take off polyps, and a chance that I wouldn't be able to get all the way to the colon end anyway. So there are risks that go along with colonoscopy, and we address those risks every time we do a colonoscopy, but to be able to decrease the number of colonoscopies we do by 1/3 would decrease the risks and the problems that patients have. So I have a feeling that's what's going to happen. So average risk, you're 50 to 75. Okay, after 75, you don't need a colonoscopy again. You've graduated. Okay, unless there's something that changes. Okay, And so between 50 and 75, a colonoscopy every 10 years. The blood testing every year, or a DNA blood test every 3 years. A flexible sigmoidoscopy every 5 years, plus the blood testing every year. Or that CT colonography every 5 years. So those are the average risk recommendations. Come on, Jim, it's time for your colonoscopy. If you're old enough to remember and know who Jim is, you're old enough for a colonoscopy. All right, high-risk patients. Now, these are people who have a first-degree relative with colon cancer. Moms, dads, brothers, sisters, kids. My dad's brother had colon cancer. That doesn't put you at an increased risk, okay? I see a lot of people, some older recommendations were that if your grandfather had colon cancer, grandmother, your uncles, then you should get a colonoscopy every 5 years. Nope. First-degree relatives or multiple family members with colon cancer and somebody less than 50. So if you have colon cancer at 70, you don't have to have a colonoscopy every 5 years. Okay? If you've had personal history of colon cancer, then you have to have more colonoscopies. If you've had colon polyps, then you have to have more colonoscopies. You don't get to do any of the other testing. You start 10 years before the age of the youngest. I do colonoscopies on people in their 20s because they have sisters or parents or brothers who had colon cancer in their 30s. Okay? So this is kind of the new things that we're working on. If we find a polyp, we look at it under the microscope, and that helps us decide when we're going to recommend seeing you back again, or inviting you back to the party, as I like to say. If there's no polyps, then a 5-year repeat on the first job. If you've done 2 5-year colonoscopies with no polyps in either one, and you personally haven't had colon cancer, then you get to go to every 10 years. So you're not doomed to the 5-year repeat forever. How can we prevent colon cancer? Take a polyp off, put it in the jar. It's never going to turn into colon cancer. Okay? How do we prevent colon polyps? We don't really know for sure. We do know that there's a lot of factors that are associated with a risk of having colon cancer and colon polyps, but nobody's found one single thing that I say, well, if you do this, you're never going to get a colon polyp. So lifestyle changes are important. Increased risk of colon polyps and colon cancer. Not very active, lots of red meat, being overweight, smoking cigarettes, and excessive alcohol use. Now, I'm pretty sure nobody's ever heard that these things are bad for you related to anything else but colon cancer too. Decreasing your risk, multivitamins with folic acid. Aspirin, adult aspirin a day seems to decrease the risk of having colon polyps and colon cancer. Now, there's other risks that go along with that, so those are things you have to balance out. Postmenopausal hormone use, although it increases the risk for a lot of other junk, it decreases the risk of colon cancer. Calcium, that's good for a lot of other things. Selenium, which is a little-known mineral. And lots of vegetables, fruits, and fiber. Now, these things are all associated. I'm not telling anybody to go out and buy $70 worth of selenium, okay? None of those are definite answers, but there's the things that can reduce the risk. All right, so if we find a colon cancer, I told you I could use that loop and take it off. So I can do that even with a flat colon cancer by injecting underneath the colon cancer. It lifts it up off of the muscle of the colon, and then I can loop that around and cut that off, suck it out, and then I usually put a little clip on there. Now that will work for a colon cancer up to about 2 centimeters, which is just under an inch. If it's bigger than that, it can be done, but not here in Grand Rapids. So if it's bigger than that, I'm going to send you somewhere else, south, to Minneapolis or to the Mayo, because they can do colon cancers up to this big, as long as they're not down into the muscle. Okay? Increases the risk of a hole in the colon, but if you'd rather have your colon in place than have a surgery and have it out, it's a good option. Surgery is another option. We can do this here. This is a laparoscopic picture. So you get a couple of 1 centimeter incisions, and I use a camera inside your abdomen to lift up your colon and free it up from everything. Then we bring it out, we staple it off, and you get an incision. This says 3 to 4 inches. It needs to be about that big because I need to be able to get my hand in there, and I need to be able to get your colon out. So your incision on your skin turns out to be about that big. Where in the old days, you got an incision from your xiphoid to your pubic bone. So different parts of the colon we can take out. We can take out the sigmoid colon and staple you back together. We can take out the left colon and staple you back together. We can take out the right colon and staple you back together. We can take out the very lowest part of your colon all the way down to the muscles of the pelvis and staple you back together. If you have a colon cancer within the last part of your colon, the last 2 inches, 2.5 inches, then most of the time you end up with a stoma, where they bring the colon out to the abdominal wall and you get to poop in a bag. It's better than dying, okay? Not what everybody would like, but if that's where your cancer is, that's one of the only options. Most other colon cancers we can treat and hook you back together, okay? Advanced cancer, that's cancer that is spread outside of the colon into the colon wall and out through into lymph nodes or the liver. This is what we don't like to find, but we still do find it because I find people who haven't had a colonoscopy, but I also find young people who are 50 years old who didn't know they had colon cancer. And they didn't know, they weren't supposed to get looked at yet, okay? So chemotherapy is what we use to treat cancer that's spread because the chemotherapy goes into your blood and it tries to kill every cancer cell that your blood goes to, which is every cell in your body. Chemotherapy is a toxin, it's a poison, and the goal is to kill every cancer cell without killing you. That's why people get so sick and so weak. Some surgeries can be done. If there's 1 or 2 spots in the liver, do a surgery to take out that part of the liver. The liver is pretty good at regenerating itself. But those are things that we don't do here. We do chemotherapy here. And that's the next little part here, the close to home. You guys have some information there. We are currently working on raising the money to create a much more patient-centered and patient-friendly area for infusing chemotherapy. We have a corner of the intensive care unit for any of you who've had chemotherapy. The nurses are fabulous. You have to share a room. It's not always the best time to be sharing a room when you're getting chemotherapy. They have to walk, people have to walk quite a distance to get to that. And so the new center that we want to have for infusion and for cancer treatment has the oncology office and the infusion center right there. So if there's a problem, the oncologist is right there. It has a separate entrance, so people can drive right up to the door, don't have to walk through the hospital. And they'll have 12 private infusion rooms so that you don't have to sit next to somebody and worry about getting sick from them or worry about how sick they are while you're getting your chemotherapy. It's also going to have some patio and a healing garden and some of the better things. And so I just like to bring people's attention to that we do chemotherapy in Grand Rapids. You don't have to drive to the cities or drive to Duluth or drive to the Mayo to get chemotherapy. Goal is $2 million. We're up to 1.45 million already, so pretty good. Colon cancer conclusions, okay? It's common, 1 in 20 people will get it, but it's decreasing. It's mostly preventable with screening. There are options for screening. Not everybody has to do a colonoscopy. And making healthy lifestyle choices can decrease the risk of colon cancer and colon polyps.
Great job.
Thank you.